Okay, good morning everybody. It's lovely to have you back again, and some of you are here for the first time and some from very far like Namibia. Willem is all the way from Namibia. And thank you for joining me again. I have had express request that we please be out of here at 11 o'clock. So I have to finish my lecture at 10:30, and then we've got half an hour for tea and so on, but we have to be out of here at 11 o'clock. And the occupational therapists are going to come and set up while we're having tea because they need to see their patients at 11 o'clock. Okay, but I'm very grateful to this hospital for allowing us to meet here and for providing the refreshments and so on afterwards. So I really feel the least I can do is to stick to the times that they've given me. I've put brochures on the tables and cards and so on. If you want to take a brochure, just to look through it, to consider if you ever have a patient that lives near here, this is a facility that is worth considering if they need to be hospitalized, okay, for psychiatric reasons. All right, so today we're going to be dealing with three main topics: the brain cells themselves, the developing brain in infants and children and so on, and then the brain in toxic conditions. Sorry. Okay, so let's start with brain cells. There are basically two types of brain cells, okay, neurons and glial cells. And we tend to forget about the glial cells, but they're actually very important too. We tend to focus more on the neurons, but let's look at the neurons. You know what the basic neuron looks like, so I'm not going to go through this. You have the soma, you have the axon, you have the myelin sheath. What we often don't realize is that there are different shapes of neurons. So, for example, you have the motor neuron that looks like this. And these are neurons that you find in the motor area of the brain, so they are responsible for movement. And they look different to, for example, the pyramidal neurons. And just that you remember that the pyramidal, it's named after the pyramid shape of its cell, the soma. And it's so the pyramidal neurons are triangular shaped cell bodies, and they're found in the cortex, also in the hippocampus, the amygdala, and particularly in the corticospinal tract. When you learn about motor movement and so on, you'll learn about that as well. The Purkinje cell looks very different, and just so that you know, that is located in the cerebellum, so it is a very unusual looking neuron. These are your multipolar neurons. Your bipolar neurons, they have two polars, your retinal one that you find in the retina and the olfactory neuron that you find in the olfactory tract. Then you also get unipolar neurons, for example, with pain and touch. And we all know that if we touch something, we feel that if it's painful, let's say it's something that's very hot, we feel that pain very quickly. And if you look at the structure of that neuron, that signal doesn't even have to go through the soma. It just keeps going. So the message can go through very quickly, and this is one of the reasons why we feel pain so quickly. And then we have an anaxonic neuron where, just so that you know, a neuron where the axon cannot be differentiated from the dendrites. You can't really see the little axon. We all know how a neural impulse works. Comes into the soma, gets passed along the axon and out. And you know that the neurons connect to each other through synapses. I'm going through this quite quickly because this is, I think, we all know this. Then you get different types of synapses. Your axodendritic, which is between the axon and the dendrite. Your axosomatic, which is between the axon and the soma, the cell body. The axoaxonic, which is between an axon and an axon. And a dendrodendritic, between a dendron and a dendron. Okay. And that's fairly easy to remember if you just understand the terminology. Here are pictures when you're studying. Do refer to these pictures. It just helps to explain it when you're trying to memorize it. You also get an axomuscular synapse, where the axon synapses directly onto a muscle fiber. And one can understand why that would be important in terms of movement. So that was a very quick summary of the neurons. Now let's look at the glial cells, which we tend to know a little bit less, or generally have learned less about. You get many different types of glial cells. I'm just going to cover some of them. We get the astrocytes, the microglial cells over there, the ependymal cells that form a lining when there's a fluid-filled cavity, the oligodendrocytes, the satellite cells, and the Schwann cells. And the Schwann cells are the ones that wrap around an axon to make myelin, the white fatty sheath. But they're not the only ones that do that. The oligodendrites do it as well. Something I just want to say about, okay, so the Schwann cells and the oligodendrites, they form a layer around the axons of neurons. But the astrocytes form a layer around capillaries. And they play a very important role in the blood-brain barrier. They are the reason why the blood and whatever else can't just come out of the capillaries. And just for interest's sake, a single oligodendrocyte can extend its processes to 50 axons, whereas Schwann cells, on the other hand, can wrap around one axon only. Each oligodendrocyte forms one segment of myelin for several adjacent axons. So you have a group of axons, and the oligodendrite will cover a group of them, whereas a Schwann cell will only cover one axon. Now, when you think glial cells, you also need to think about tumors. I mean, we often are referred people who've had tumors or their tumors have been removed. So if someone is talking about a person had an astrocytoma tumor, it is a tumor of the astrocyte. If they have a schwannoma, it is a tumor of the Schwann cells. And if they have had an oligodendroglioma, it's a tumor of the oligodendroglia. Okay. They sound like very big words, and they are, let's face it, very big words. But if you understand where the neurons and the glials come from, then you also understand the tumors. Now, just regarding other brain tumors, while we're talking about brain tumors, you get meningiomas attached to the meninges. That makes sense. And then you get metastatic tumors, which are established as a result of tumor cells from another part of the body. And metastasis means the transfer of disease from one organ part to another. Okay. Now, in our cortex, the outer part of our brain, we have several layers, and they're very distinct layers. If you had to dissect the brain and stain it and so on, you'd be able to see the layers. There are 6 layers. Now, in this picture here, I've got the primary sensory cortex. So if you had to imagine where the primary sensory cortex is, and you had to cut out a little piece of it, that is what you'll see. If you had to cut a piece out of the association cortex, that is what you'll see. And out of the primary motor cortex, that is what you'll see. So layers 1, 2, and 3, here's layers 1, 2, and 3, 1, 2, and 3, and 1, 2, and 3, receive input mainly from layer 4, and it's well developed in the secondary and tertiary areas. Okay. Layer 4, this one there, receives axons from sensory systems and other cortical areas. Now you can see here in the primary motor cortex, this layer 4 is very thin because it doesn't receive many axons from sensory systems and other cortical areas, whereas the primary sensory area receives a lot, and the association also, although less. And then layers 5 and 6 send axons to other brain areas. So your primary motor cortex that is sending axons out, you can understand why layers 5 and 6 are so thick. Okay. Now we're going to come back to this again in a little while. And we're going to look now at the developing brain. So we've looked at the very, very basics of the neurons and the glia. You need to know that. Now we're going to look at the developing brain. So when I refer to developing brain, I'm talking about from conception, how that brain develops. After birth, how the brain continues to develop. Okay. Also, to some extent, towards the end of life, old age, what happens to the brain then. But I'm talking more about the early years, childhood years. So let's look at the stages of brain development. At 14 days of conception, after conception, several sheets of cells have a raised area in the middle. Okay? And at 3 weeks, the sheet of cells at one end of the embryo, the primitive brain, the sheet rolls up to form the neural tube. So here you see it's rolling up, forms the neural tube. Okay, that's at 3 weeks after conception. Now, this is the pictures of the brain up until 9 months. So at 100 days after conception, over here, the brain starts to look human. At 7 months, over here, the gyri and the sulci start forming. And at 9 months, the brain has a gross appearance of the adult human brain, but its cellular structure is still quite different. Now, there are different stages of brain development. You have cell birth, neurogenesis and gliogenesis, cell migration, cell differentiation, cell maturation, synaptogenesis, cell death and synaptic pruning, and myelinogenesis. So let's just break that down and see what does that mean. So cell birth, we're really talking about new cells are generated, the neurons and the glial cells, they're generated. Then they move to where they need to be. Okay? Once they're there, they change to become the types of cells they need to be, depending on where they are in the brain. Then they grow dendrites, and the axons grow longer. Then they link up with other cells through synaptogenesis. And then the ones that need to die do, and the synapses that were not supposed to form get undone. Okay, so you have a whole lot of cells connecting, and then there has to be some pruning for the brain to function properly. And then myelin gets wrapped around the axons to increase the speed of message transmission. So those are the basic steps of the development of the brain at a cellular level. Now let's look at neural stem cells. There's a lot of information about neural stem cells, and when one tends to think of neural stem cells now, you think about the issues regarding transplanting neural stem cells for brain development. People who have brain injuries and spinal injuries. But there's still a lot of research that needs to be done. But you do find neural stem cells in the neural tube. And I just want to say, just in case you don't know, you know that stem cells are your basic little cells that can develop into any other cells. That's why they're so important. So they are found in the neural tube. They have an extensive capacity for self-renewal. But when a stem cell divides, it divides into two, and the one dies, and the other one lives to divide again. Okay, so here you have a little stem cell. It can renew itself, but it can divide into either a neuronal progenitor or a glial progenitor, which means it could become a neuron or a glial cell like an astrocyte or an oligodendrocyte. Now, these neural stem cells, in adulthood, okay, so we know at conception neural stem cells are found in the neural tube, but even in adulthood you find some of these stem cells, and they are in the lining, they line the ventricles. Just look here, you remember the brain, you know the ventricles, these empty spaces inside the brain. Now, these neural stem cells line the ventricles and form what we call the ventricular zone. If you look at this coronal slice here and you're looking at the lateral ventricle, here's the subventricular stem cell zone there by the ventricles. Okay. And they give rise to progenitor or precursor cells. These can also divide, but eventually produce non-dividing cells known as neuroblasts and glioblasts, which mature into specialized neurons and glial cells. Okay. Now, these stem cells continue to produce neurons and glia even into early adulthood and even in the aging brain, but only in two places, in the olfactory bulb and in the hippocampus. Let's talk about cell migration and differentiation. So you know that the cells move to where they need to go in the developing brain. In an adult brain, it's completely different because they're already there. Okay. That is why it's so much more difficult to do a neuropsychological assessment on a child than on an adult. Because with an adult, you know where those brain cells probably were before the person had the injury. So you can predict how that would affect the adult. But with a child, some of those neurons might still be moving to where they need to be. So you need to look very carefully at the age of the child, and you need to consider where those neurons are likely to be. Would they already have been in place at that age or not yet? So it becomes very tricky to assess a child. So the cell migration begins shortly after the first neurons are generated, but continues for weeks after neurogenesis is complete. So even after the brain has stopped making neurons, the neurons are still busy moving. Okay. The migration of cells continue for a number of months, even up to 8 months after birth. So a baby that is under the age of 8 months, their cells are still busy moving. Now, after the first 4.5 months gestation period, production of neuroblasts is almost complete. Okay. During the last 4.5 months of gestation, so that's during pregnancy, the brain is very vulnerable to injury and trauma. So if you have a child that's being assessed and the injury occurred while the mom was pregnant and was in the last 4.5 months of that pregnancy, you know that it is very likely that brain was very vulnerable at that time. And some of the thinking behind this is that why in that last 4.5 months, why the brain would be more vulnerable then is perhaps because the neurogenesis has stopped and is not easily started again. So you have a period with these little neurons being made, and then it stops. So if a baby still in the womb then has an injury, those neurons can't regenerate. Okay, and there aren't new ones being made. Okay. Now I put it in a diagram like this just to help you to remember it. And if you deal a lot with children and infants and so on, it might be worthwhile just printing it out and keeping it in your drawer or something. Here we have months of pregnancy, 1 to 9, and then you have birth and up into adulthood. Now, cell differentiation happens after the completion of general neurogenesis. Cell differentiation begins when neuroblasts become specific types of neurons, and it's completed birth. So here you have your neurogenesis in the beginning, and then your cell differentiation, okay, up until birth. Cell migration begins shortly after the first neurons are generated, but continues for weeks after neurogenesis is completed. So it starts about there and then continues for quite some time. Neuron maturation, this includes the growth of dendrites, axons, and synapses. It continues for years and may continue into adulthood in some parts of the brains. So here you have your neuron maturation, and it just goes on for a very, very long time. Now this is very interesting. You get what you call radial glial cells. So these are also glial cells, again, a different type of glial cell. Radial glial cells are like roads from the ventricular zone to the cortex, guiding cells to where they need to be located. So we know these little cells are moving, but how do they know where to go to? How do they know where to get to? These radial glial cells stretch from the ventricular zone to the cortex and to the correct layer of the cortex to guide them where they need to go. And here we get to the layers of cortex again. This is where it starts to become very important. So you have layer 1, 2, 3, 4, 5, 6 of the cortex. Okay. Now with normal migration, successive waves of neurons pass earlier arriving neurons to assume progressively more exterior positions in the cortex. So you have some, and they almost do a bit of a relay, well, they go past each other until they get to the more exterior positions. migration can stop prematurely, leaving cells that should be in the outer layer scattered amongst the inner layers instead. So that's when something goes wrong and they don't get to the outer layer. And the consequences of that are often dyslexia or epilepsy. Now, when we think about neural maturation, what do we mean? The neurons mature, but what does it mean? It means, firstly, the neurons grow dendrites, not the arborization, where they're making new branches, but also the spines on the dendrites. Their axons become extended, and dendritic development continues long after birth. And sometimes you have disruption of development of the neural pathways. So an axon may fail to reach its target of its path. An axon may fail to reach its target if its path is blocked. Example, due to scarring from an early head injury or in the early months of life. So something might stand in its way, it doesn't get to where it needs to go. It may be inhibited by the ingestion of toxic materials through malnutrition or other disturbances. But again, it doesn't reach where it needs to go because it's inhibited. Some abnormalities might have a genetic basis, we can understand that. If an axon's target is damaged, the system may degenerate, or the axon may connect with an inappropriate target. So you've got this axon growing, it needs to connect to certain other neurons, and maybe that target where it's supposed to connect with, there's something wrong with it. Well, then that axon might just degenerate, or it will hook onto something else, and with some potentially very interesting results. Now, the synapses, we form synapses, and synapses get pruned, and there are different phases of it. So let's look through that. Phase 1 and 2 is before birth. It's the generation of low-density synapses, and they are generated independently of experience. Because you can imagine this baby is still in the womb. It is having experiences, but it's fairly limited. And this synapse formation is generated independently of experience. Then you get phase 3, where there's rapid synapse growth. It begins before birth and continues for nearly 2 years after birth. Synapses are formed by experience expectant and experience dependent mechanisms. So let's look at what those are. Experience expectant mechanisms. The synapses develop depending on the presence of certain sensory experiences for the organization of cortical circuits. For example, for the visual cortex, a baby needs exposure to features such as line, orientation, color, and movement. So what it's saying is that the brain is expecting to have certain experiences. If it doesn't have those experiences, the child is impaired. So you're expecting a baby will be exposed to color, form, lines, and that's not just in the visual areas. From an auditory point of view, they'll be exposed to language, music, other sounds. And the general pattern of these synapses is presumed to be common to all members of species. So in human beings, the assumption is all babies, unless something has already gone wrong, has this experience expectant process. Then there's experience dependent. Synapses develop depending on experiences that are unique and personal. For example, the features of a specific face, that baby's mother's face, that baby's father's face, music that the baby is played for the music, music that is played for the baby, voices that it hears, tones of voices, and when it's older, thoughts that might be grappled with. Okay, so those are experience-dependent mechanisms that affect the synapses that take place. So now we know why we've known for a long time, it's important that babies get the right sort of stimulation. Then you get to phase 4. There's an initial plateau in the synapse, in synapse formation just before puberty, followed by rapid elimination of synapses that continues through puberty. So now we know why teenagers are so mixed up. It's because there's rapid pruning of synapses. The rate of loss may be maximal in puberty, Synapses are also formed by experience-expectant and experience-dependent mechanisms. So again, right through a child's life and into puberty, what they're exposed to, what they hear, what they do, what they feel, has to do with how their synapses are being pruned and formed. Then you get a plateau of synapses again, of synapse number through middle age, followed by a slow, steady decline in the density of synapses with advancing age, and a final drop in very old age, just before death, if you die when you're very old. Okay. So, again, still looking at synapse formation and pruning. This is just a diagram that just illustrates some of the synapses and some of the pruning, because there's a very definite format. It doesn't happen in a arbitrary way. There's certain things that unfold at certain times. So let's look at your sensory pathways for hearing and vision. Just over here, these are your months before birth. These are your first year, the months of your first year of your life, and these are the years after that. So if you look at your sensory pathways for vision and hearing, they pretty much start in your first year of life. There's a rapid increase, and then there's quite a rapid decrease again to the end of the first year of life, and then it tapers off somewhat. Language starts later, or most of the synapse formation is later in that first year of a child's life, and then rapidly declines again. No one knows why it's so important, why in that first year of life a child is exposed to language. And your higher cognitive functions are later, and then also taper off, reaching a peak here at about the age of 1 year. Okay. So that's a synapse formation. Okay. Now this slide, sorry, I've got such a frog in my throat today. This slide you won't find in your Colburn Wisher books. I put it in because it's so interesting. And I discovered it when I was busy preparing for my tutorials last time. And I thought I'd keep it in because I think it's very much of relevance to us. Now, this is a slide regarding dendritic spine pathology. Okay, the spine's on the dendrites. And if you look at autistic spectrum disorder, is the purple line. Okay, let's just go explain it. This is now before birth. Here's birth. There's childhood, adolescence, adulthood. Okay, and this break just shows that there are many years of adulthood that aren't being shown there. So let's look at children with autistic spectrum disorder. In birth, before birth, it follows a pretty normal curve, although it's a little bit higher. And then look what happens during early childhood. It's much higher, and then it slowly starts petering off. You have many more dendritic spines than the normal person. Here's normal. This black line is normal, okay, which is very interesting. Now let's look at people with Alzheimer's disease. They follow very much a normal curve until your old age, and then they drop off significantly. And then your schizophrenia also, just interestingly, follows a very different pattern. There's a synapse elimination down here, and then it slowly peters into adulthood. So I've put in the name of the article that this comes from for you to go look up if you work with people with Alzheimer's or autistic spectrum disorder children or schizophrenia for more information. But what we can see is that our synapses and how the dendritic spines and so on are formed, and when they prune, can have a lot to do with our development, our psychiatric development. All right. So let's look at glial development. We've looked at synapses. Let's look at those glial cells. Now, glial cells, such as astrocytes and oligodendrocytes, although we know we get many other types of glial cells, their genesis begins after the neurons are born, and their genesis continues throughout life. And I just put these two reminders in of what the astrocytes do and what the oligodendrocytes do. But just in a nutshell, the oligodendrocytes help form myelin around the axons, for several axons at a time. The astrocytes tend to wrap around the capillaries and help with the blood-brain barrier. So talking about myelin, while axons can function without myelin, they only function optimally once myelination is complete. So once there's a layer of myelin, it functions, your messages get transferred along those axons quicker, more efficiently. And myelin is a useful rough index of cerebral maturation. The older a child, the more myelin they'll have. Myelination begins just after birth and continues till about 18 years of age. So it's only at 18 that our brains our processing speeds are really become optimal, because when the axons are myelinated, it increases processing speed. And just interestingly, the different cortical areas are myelinated at different times. There's certain patterns of myelination. So some cortical regions are myelinated at 3 to 4 years of age, whereas others are only myelinated much later, such as the areas controlling higher mental functions. So again, your higher mental functions only function properly at a later age, but your cortical areas, for example, vision and hearing and so on, will be myelinated quicker. So while we're talking about myelin, what immediately comes to mind when I was thinking about pathology of myelin is multiple sclerosis. So here's a picture of your neuron. Here's your axon, and it's myelinated. This is normal myelin here. This is damaged myelin. So when myelin gets damaged because of multiple sclerosis, you're going to have impaired functioning to some extent, because those messages are not going to be transferred as easily. Why I discuss these pathologies while I'm discussing the functioning is just, I think, while I'm thinking about certain things that work in the brain, it's helpful to think about the things that can go wrong. Okay. Now, our gray matter also gets reduced and needs to be, because remember, we have a lot of connections, a lot of brain. It needs to be reduced for our brains to function optimally. In children now, I'm talking about in children. So reduction in brain matter begins in the primary areas and spreads to secondary and tertiary areas. Our primary areas, again, being your primary visual areas, your primary auditory areas, and so on, and then spreads to the secondary and tertiary areas. Primary cortical regions controlling basic sensory and motor functions are thus the first to mature. Areas controlling space and language mature at puberty between about 11 and 13 years. So if you're testing a child that's beyond the age of 13, their spatial and language functions should be about as good as they're going to be. I'm not talking about language learned, I'm talking about language ability. Tertiary cortical areas, such as the prefrontal cortex, begin to mature last in late adolescence and continue well beyond. So it's only late adolescence that your frontal cortex really becomes optimally functional. And cortical maturation continues until at least the age of 30, but possibly longer. Okay. So those of us who are older than 30, which I think is all of us, can say, well, we've got very mature brains that have done everything it needed to do. So I just want to give you some extra information, because this also becomes very important when we're assessing children. Okay. So post-birth development. Now, this information you'll get from a book called Developmental Neuropsychology, A Clinical Approach by Vicki Anderson. This is a book I can strongly recommend if you're working with children. Not an easy book to work through, but it has a lot of information that's very valuable. And these are just things taken from a book. So at age 3 months, a baby at the age of 3 months, there's a burst of synapses for visual and auditory cortex. Okay? Between 4 months and a year, there's a relative synaptic maturity for visual and auditory cortex. At 7 years, the synapses for vision is complete. So then they can see fully. Well, the synapses are complete. From 8 to 15 years, the synapses continue in the frontal cortex. Between birth and 1 year, there's a dramatic increase in myelin. It's a vulnerable period for myelination during the first 8 months of life. Hippocampal and other limbic structures and the reticular tract still mature, myelinate at school age. Prefrontal areas are one of the last areas to be fully myelinated, with considerable myelination continuing during late childhood and early adolescence. And I know I'm repeating myself to some extent here, but I'm sure you don't mind. I think sometimes I also need to hear things over and over for it to start to sink in. Now, in terms of frontal lobe development, there are certain growth periods and growth spurts. There's a growth period between 1 and 3 years. Then there's a growth spurt at the age of 6 years. Then a growth period again between 7 and 10 years, and a growth spurt at 10 years. Another growth spurt at 13 years, and then a growth period from 16 to 20 years. And if you go and look at Piaget's theories, and you look at his sort of how at what ages he noticed children were going to a different cognitive level, you'll see it matches up very well with us. Now, of course, there are environmental effects on the brain even before birth. Obviously, much more chance of it after birth, but before birth as well, for good and for bad. And so tactile, one can't very well go do research on babies that haven't been born. Okay, so they do a lot of research on rats to look at, what happens with rats. And one thing that was found is tactile stimulation of a pregnant rat. I think they brush the rat. She's pregnant, they brush her. Improves the motor and cognitive outcome of her offspring. Okay. Good reason why your husband should give you a massage if you're pregnant. Okay. But stress has the opposite effect. Exposure to therapeutic drugs, such as antidepressants, may interfere with a normal human brain development, which is why with pregnant women are told to rather stay off the antidepressants. Hormones, injury, and abnormal genes obviously also have adverse, or can have adverse effects on that development. And then environmental effects on the brain development after birth. The environmental stimulation can enhance development. By environmental stimulation, it could be anything from massaging a baby, playing music, singing, rocking, enhances development. But environmental deprivation can retard development. And the earlier the deprivation, the more damaging the effects. Okay, so if you're assessing a child, that's why we need to get that early history of the child, the early years of the child, find out, is there anything going on in that child's development at that stage that one needs to be aware of. And when one thinks of brains, children's brains, you tend to think of plasticity. And there's this theory at one stage that children's brains are very plastic. So, if they incur injury, they tend to improve more quickly than adults and so on. And with more research, what has been found is that is completely oversimplified. It's a lot more complicated than that. So here's some of the more recent findings. The ultimate effects of a brain injury on a child depends on the age of the child, very much. The extent of the damage, obviously, and the location of the damage, again, quite obviously. And there are 3 critical age divisions. Before 1 year of age, a child who has a brain injury then has disproportionately greater impairments. So it's a very bad time to have a brain injury if you're younger than 1 year old. But between 1 year and 5 years, that's when the brain has the most plasticity. And the brain then tends to reorganize its functioning, mainly for the purpose of rescuing language functions. So it will rearrange itself so those language functions are rescued, but to the detriment of other areas. So you get this crowding effect. If the left area of a child between 1 and 5 is damaged, the brain often shifts those language functions to the right hemisphere, but it's at the expense of visuospatial functions. You'll find those children, their visuospatial functions aren't so good, even if their language functions are spared. And then after 5 years of age, there's little or no sparing of function. So if the child is older than 5, they have damage in the verbal areas, they just lose that functioning. There's no sparing of functioning. So if you're assessing a child, always think, is this child under 1? Is he or she between 1 and 5 years or older than 5 years? Becomes very important. And where is the injury and to what extent is the injury? Okay, that's why I say it's very complicated to work with children. I think a lot of people want to work with children because they think it's easier. It's not in neuropsychology. And then just another important thing to bear in mind is that children who incur prefrontal injuries in infancy or early childhood have very poor outcomes. Okay, the prefrontal areas specifically. And some more effects of early brain lesions. Sorry. Sure. Did it stop? Or do you just need to take a break? Are there any questions while we're taking a break? Is this okay? Are you? Do any of you work with children? So very young, do neuropsychological assessments on very young children? Okay. I think in the not too long ago, if you did a neuropsychological assessment on a child, you do the S-size and the J-size and speak to the parents, and there's your assessment. It's obviously much more complex than that. Okay, can I continue? All right. So let's look at the effects of early brain lesions. Brain damage in infancy causes the brain to be smaller than average in adulthood. The earlier the lesion, the smaller the brain's ultimate size, because there are fewer dendritic fields, fewer synapses, so the brain just is smaller. Okay. Now, again, some studies done on rats. In rats, injury at day 10, it's a very specific time, led to reasonable recovery, but injury at day 1 to very poor recovery. Again, that thing of if an infant is very young, there's a very poor outcome, but at a certain time of a baby's development, there's a reasonable outcome. So with the rats again, after day 10 lesions, there are many more astrocytes which support the growth and differentiation of neurons. But this was not the case with day 1. Now, we're talking here about rats, but I think one can assume that something similar applies to human beings. That in a child younger than the age of 1 year, just a very young child, you don't have the astrocytes that are there to support the growth, because they only come about later in the child's life. Now, connections that are not pruned correctly, because of course that can also happen. We know that it gets pruned, but sometimes it doesn't get pruned correctly. If an injury is too early, can lead to aberrant connections. But aberrant connections are not always harmful. For example, in the case of synesthesia. Do you know synesthesia? Do you know what synesthesia is? Synesthesia is a fairly common phenomenon where people will associate, the typical example, will associate colors with numbers. So if they think of the number 1, they think, for example, of green. That 1 is green, and number 2 is red. And so if you have a number 12, you have sort of a mixture of green and red. And I've spoken to a number of people with synesthesia, and it's actually very interesting to hear what they say. For them, if you do, for example, digit span, they don't just remember the numbers, they remember the colors as well. And that's just because the brain has kind of connected in an unusual way. But synesthesia is not uncommon. So what are all the things that can go wrong with a child that's brain's developing? I want to mention here learning disabilities, and I just want to make it very clear that learning disabilities is an umbrella term. If you're ever referring to learning disabilities, you need to be very specific about what you mean. Are you meaning that the child can't remember, that they can't learn? Are you meaning that they can't read? Are you meaning that they can't write? Or all of the above? You need to be very specific about what you mean. And so it's an umbrella term, and it's used for a variety of school-related problems where the child struggles to learn, but has adequate intelligence, adequate opportunity, adequate instruction, adequate home environment. And dyslexia has been central to studies on learning disability for many years now. The other thing that comes to mind, if you think about children's development that isn't optimal, is the hyperactive child syndrome, ADD, ADHD. And you can read up in the slide. These slides that I'm going to be talking about now, about the types of disorders, they're really just introductory. So I'm going to go through them quite quickly because I want to get to the next part. We have ADD, we have cerebral palsy, we have hydrocephalus, autism spectrum disorder, Fragile X syndrome, which you'll read about and learn about in Carbon-Wishaw, fetal alcohol syndrome, which I think we tend to see quite a lot here in the Western Cape. All right. And then what are the risk factors for anomalies in the central nervous system? Prenatal factors like maternal stress, nutrition, etc. Postnatal factors, again, like nutrition, cerebral infection, anoxia, etc. And then I just mentioned the birthday effect here because although there's nothing wrong with a child if they experience the birthday effect, do you know what the birthday effect is? You have a child who's born late in the year. So let's say November, December. So they're almost a year older than some of the children in their class. And a year of brain development is a long time for a child. So their brains haven't developed to the extent of their peers, obviously depending on when their peers' birthdays are. But let's say arguably there's a child born in January and a child born in December. There's nearly a year difference. So that child is always a little bit slower in class, obviously also depending on IQ and so on. But they'll be a little bit slower on the sports field, they'll be a bit slower in class, they'll be a bit slower with their speech development, and they tend to then not get into the sports teams, for example, so they don't get the extra practice. So they don't get better at the sport, and then they keep falling behind, and that's a birthday effect. It's a big problem because no matter where you draw the line, there will always be children that are nearly a year older than others in a class. So let us look at the brain in toxic conditions. Okay, so I've now dealt with the developing brain. There's a lot of information there. You need to go and really study, look through it very carefully. And if you're working with a child, always go back. Look at what is the age of the child, what is the age of the injury, where was the injury, and consider that very carefully. But in these last few minutes, I want to talk about the brain in toxic conditions. Now, we have the blood-brain barrier, where we have these capillaries in our arteries and capillaries in our brain. And water and oxygen and glucose are allowed to pass through into the brain, but nothing else. It's very protected, the brain. And that is also why drugs and so on, I'm talking about psychiatric medication that's prescribed. It's got to have a certain consistency to be able to get through the blood-brain barrier. And the reason it is the way it is because the astrocytes around the capillaries that try and prevent anything unnecessary coming through there. Now, here is a list of psychoactive drugs that obviously affect us, things like benzodiazepines, morphine and heroin, caffeine, and your psychedelics and hallucinogens. You just need to know what they are. Alcohol-related disorders is quite prominent. When we think of alcohol-related disorders, we think of chronic alcoholism, alcoholic dementia, Korsakoff syndrome, street drugs affect us, and then social drugs. But we also need to consider environmental and industrial toxins. So if somebody's coming to see us, we need to find out what type of work were they doing. I'm thinking about an adult now, so we're talking about adults. Did they work in an environment with a lot of pesticides? You know, were they farm workers, for example? You need to take that into account. Does a person have HIV or herpes or Lyme disease? Lyme disease is a tick-borne infection. It's not very common in South Africa, but one does need to know about it. And then chronic fatigue syndrome, I think there's a lot of uncertainty about exactly what that is and what it isn't. One also needs to think about oxygen deprivation because the brain doesn't get enough oxygen. The brain is very, very needy of oxygen. So if a person is deprived of oxygen, it is the first thing to suffer. And you need to think about, was there any sort of carbon monoxide poisoning at a stage in a person's life? Because then they're not getting enough oxygen. Are they smokers? Because smokers don't get enough oxygen in. And were there periods of hypoxia or anoxia where the person couldn't breathe? Is there maybe a lung that collapsed? You know, is there anything that could have caused the person not to get enough oxygen? Were they trapped in a small space after an accident and they couldn't get enough oxygen? You need to always think about oxygen. And when you look on, for example, emergency records and so on of ambulance reports, always look to see what is the oxygen saturation because they test it quite quickly. And if it's low, you need to you need to remember that that might have been the cause for a person's, for poor brain functioning rather than maybe the accident itself. Nutritional deficiencies. If a person has anorexia nervosa, you need to wonder about whether that would have affected the brain as well because of nutritional deficiencies. And folic acid deficiencies and vitamin D deficiencies amongst other vitamins. One just needs to look at the person's general health. Do they eat healthily? If it's let's say it's a young person at university and they're looking after themselves, they're living at home, are they eating properly? Or are they eating chips and sweets and Coke for dinner? Are they really getting enough nutrition? Okay. Now, your reading that you need to do, it doesn't look very much because it's quite a short list, but there are 3 major chapters that I need you to go through between now and when I see you again. And what we include now, besides the cold book, is I'm going to read quite a lot in LESAC. LESAC has excellent chapters on the toxic conditions that affect the brain, like carbon monoxide poisoning and street drugs and social drugs and oxygen deprivation and so on. There's quite a lot in her book about that. So it's a good time now to go and read up on all of that and try and memorize that. Okay. Are there any questions?
Just a general question on the reading. There's a lot of, not a lot, but there's some references to tests that one can use to assess certain things. Do we need to know those tests? Are they relevant to us? Will they be asked?
For the exam? Unlikely. I think because it's quite a difficult area because a lot of our tests on reading are not South African tests, and I think, I personally find it very difficult to try and assess a person's reading age because of the differences in languages and the tests that we have that aren't in the person's home language and so on. But you don't need to know those tests really.
At the last tutorial, we spoke a lot about sight, vision, and hearing. So that hasn't been on the reading list. Is that something we need to study on our own, or is it still coming up?
We are going to come in about 2 or 3 tutorials time. We're going to be looking at the whole visual system and the whole auditory system, and then it will come up a lot. So you can wait for that. I mean, of course, you can read it so long in the meantime. I mean, it's sounding very positive. Sounds like you're keeping up to date. Other questions? Yes.
The later development of the higher functions, etc. Would that indicate that the ADHD symptoms or the executive functions symptoms that you see with kids would necessarily then improve?
I think the reason a lot of children do improve spontaneously is because those areas are still developing. But one can't predict it until one knows exactly why this child is having difficulties compared to his peers. So one can't really say this child will definitely improve.
But one must obviously take off the meds at some point to see.
Yes. I think as they get older, yes, it would be very wise to take them off the meds to see how they're functioning now. Because maybe there's been enough development that they don't need it anymore.
But it's not a definite thing that it will.
It's not a definite thing. It's more, you can look back and say, oh yes, the reason this child doesn't have any problems anymore is because they've matured. But you can't do it the other way around. Because not yet. The research is still we just don't know exactly what is causing it. So we can't really predict how it's going to be in the future.
And the autism research, is that now a definite research one can share with parents, or is it just a theory?
When you talk about autism research, which aspect of it?
In terms of, what actually causes them autism and our brain development.
That is one component of it. That just had to do with the synapses and so on. So that is one component of it. My understanding is there's too little known about autism to really be able to tell a parent what caused it. They want to know if they're somehow at fault or if it's genetic and if their other children are going to have it.
So this is not something one can necessarily share as a causal fact.
You can share it with them as an interesting fact, but say to them that it's not necessarily a causal fact in their child's case. Something else might have been a causal fact. Thank you. I'm so glad I got through this in an hour because I was really concerned I wouldn't, as that was a lot of work. Okay, thanks for listening so carefully.